This case is a 56-year-old male patient presenting with a 47 milliliter prostate. The bladder neck has an acute angle and also it's very narrow. So in this case, we scheduled the patient for a MiLEP procedure with a 22 French laser resectoscope and a Pulse Thulium YAG laser from the Dornier company. And after checking for the ureteral orifices, the first step of the procedure is to do a U-shaped incision around the verumentanum. Our laser settings are 2 joules of energy and 50 Hz of frequency for enucleation in the short pulse mode, and also we apply the 0.6 joules of energy and 50 Hz of frequency in the long pulse mode for the coagulation. So now we are doing the incision of the mucosa around the verumentanum, and in these small prostates usually finding the enucleation plane is not so easy. These small prostates are actually good candidates for the En-Bloc enucleation of the prostate. The beauty of En-Bloc technique is you don't spend a lot of time with the incisions. However, in this patient, the bladder neck has an acute angle and it's also very narrow. So to ease the procedure, I am performing now a 5 o'clock incision starting from the bladder neck down through the verumentanum. While doing this incision, I'm not doing the incision very deep at the first step, but I incise the mucosa first and do my incision gradually. And the depth of the incision is determined with the plane that I found at the level of the verumentanum, so that I avoid doing a very deep incision at the first step that will cause bleeding. The high peak power provided with the Pulse Thulium YAG laser is very helpful while doing these incisions, and at the same time the laser provides excellent first pass coagulation and we don't see any bleeding while doing the incision. After completion of the 5 o'clock incision, now I'm incising more laterally at the posterior aspect. And now, in order to ease the procedure, I turn the laser probe upside down and now it's located in the 12 o'clock position. By this way, I can apply the laser energy much more easily through the surgical capsule. And as you can see, with the high peak power of the laser, I can fire from a distance and separate the adenoma from the capsular plane. And at the same time, the first pass coagulation is excellent. So after creating some space in the posterior part, now I'm going through the lateral part of the left lobe. And while doing this, still I keep my laser fiber at the 12 o'clock position. And now I'm incising into the adenoma at the level of the apex. And here the idea is to spare some adenomatous tissue at the level of the apex in order to protect the sphincter. So after incising a little bit into the adenoma at the apex, it's much more easy to go to the more lateral part of the adenoma. So now I'm going more anteriorly and also gain still some space in the posterolateral part of the left lobe. And after doing some dissection at this level, now I turn my fiber into the 12 o'clock and incise into the adenoma at this level in order to perform the early apical release. This is an essential step of the procedure in order to prevent the early stress urinary incontinence after the procedure. So after sparing the sphincter at 12 o'clock position, now there is no stress on the sphincter so that I can do my lateral dissection much more easily and also gain some posterior space more and continue with the enucleation of the left lobe. So at this point, more than 50% of the enucleation of the left lobe is over. And I just select some reference points in the posterior and anterior parts and firing the laser from a distance with the no-touch enucleation method in order to separate the adenoma from the capsule. Now, after doing some enucleation on the left lobe, now I'm going to do the enucleation on the right and the median lobes. So it's important to go with the symmetrical way. By this way, the anatomy will not be so distorted. And now I'm firing with the laser fiber again in the 12 o'clock position at the posterior part of the right lobe and the median lobe. So here, the idea is first to generate some space in the posterior part and then go more laterally and try to go to the anterior part of the right lobe. So here again, I'm incising into the adenoma, just like the left lobe, and continue that plane with my plane coming from the posterior part. So the idea is to find the enucleation plane once and follow it on the posterior and lateral aspects. And after gaining some space in the posterolateral part, now it's going to be the turn for the anterior part. So now I have enough space in the posterolateral part of the adenoma, and so I can just drag my fiber back to the level of the sphincter and incise into the adenoma to cut the mucosa of the sphincter, and by this way the early apical release is complete. And I'm trying to connect the lateral part of the right lobe more anteriorly to the lateral part of the left lobe so that the entire adenoma is now released from the sphincter and it's in my hands. And I'm still applying the laser fiber from a distance at the 12 o'clock position, and this is the most convenient way. Because I can press the adenoma from the anterior part and fire my laser with respect to the global structure of the prostate. So now I can turn all around the prostate. This is the 10 o'clock, 11 o'clock, 9 o'clock positions, the lateral part of the right lobe, and continue my enucleation plane to the opposite side. Now it's 1 o'clock, 2 o'clock, 3 o'clock positions, and I can reach the posterior part of the left lobe now. So now I'm going in the counterclockwise direction, and I'm almost reaching the bladder neck because I can see the vertical fibers at the level of the bladder neck instead of the horizontal fibers in the more proximal parts. So I'm trying to go symmetrically all around the prostate until I reach the posterior part that I have divided with my 5 o'clock incision. And coming more anteriorly, now I can see the vertical fibers much more easily, and I'm sure that the bladder is just in front of me. So before entering the bladder from the anterior part, I'm doing some more dissection on the lateral and posterior part of the right lobe, going more anteriorly, and also try to do the dissection symmetrically on the left side as well. And by this way, when I enter the bladder, it will be much more easy to complete the enucleation. Now I enter the bladder from the 12 o'clock position, reach the bladder, and now cutting the bladder neck fibers in order to open up the bladder mucosa. And now I have a better vision from the lateral part, and as I had a very good distance on the posterior part of the prostate, I can reach the bladder from both sides. So this is a view from my 5 o'clock incision, and I'm dissecting more on the posterior part of the left lobe, and there is only a very limited tissue attached in the posterior part. All the lateral and anterior part of the left lobe is already enucleated. And now the enucleation of the left lobe is completed, and only the posterolateral part of the right lobe is attached. Now I'm firing through the adenoma in the posterior part in order to prevent undermining the bladder neck. This is crucial because the most important perforations occur at the posterior part near the bladder neck. So in order to finish the enucleation, now I select two reference points, one looking through the bladder on the lateral part and the other one is looking through the bladder on the posterior part. And my aim is to unite these two reference points. And at this step, I'm intentionally firing into the adenoma, and by this way, I prevent undermining the bladder neck in the posterior part. So to complete the enucleation at this step, I need to cut the final attachments at the level of the bladder neck. And still, I'm keeping my laser at the 12 o'clock position and holding the adenoma anteriorly, and now the enucleation is completed. First, I'm gonna check the ureteral orifices in order to see they are safe. And this is the right UO, and there are some small glitters at the bladder neck. This is the left UO, and after seeing that, I do a little coagulation at the level of the bladder neck. But I really do not have a lot of important bladders here because the first pass coagulation by the laser was excellent, so I don't spend a lot of time with the coagulation. And after doing so, I changed the telescope with the morcellation scope that's compatible with the 22 French sheet and start the morcellation of the adenoma inside the bladder. But I also like to make the morcellation inside the fossa, so I pull the adenoma into the capsule and try to do the morcellation inside the capsule. This has several advantages. First of all, you don't have any risk of injuring the bladder mucosa, and together with that, the adenoma is more stable and it doesn't move anywhere. So by continuing with the morcellation, the adenoma gets smaller and smaller, and afterwards, while I'm inside the prosthetic capsule, I usually rotate the morcellator blade around 30 degrees so that it's much more convenient for doing the morcellation because I can see the movement of the adenoma much better, and when I drop the adenoma from my blade, I can catch it up much more easily. So morcellation is usually the boring part of the procedure. However, we should always be very careful while doing the morcellation, and we should always keep the bladder full while doing the morcellation in order to prevent any bladder damage. So to establish this, we connect another water source into the nephroscope, the morcellation scope. So now I'm keeping my morcellation blade with a 30-degree angle here, and so that I can see the movement of the adenoma much better. And also when I drop the adenoma as I'm in the capsule, it doesn't go anywhere, and it's a very fast morcellation procedure. So in this case, the entire anesthesiology time takes just less than 20 minutes, and the surgery is completed in less than 15 minutes. And in these small glands, in these small prostates, I think the MiLEP is a great option with the durable outcomes, fast procedure, very minimal bleeding, and you can discharge the patient in the same day or the next day. And I would like to thank you all for your attention.